Good afternoon. Welcome to today's joint press briefing between the Ministry of Health of Rwanda and the World Health Organization. I'm Stella Mucho and I'll be moderating this session. I'd like to first start by welcoming our two speakers, who is the Minister of Health, Dr. Saban Sanzimana, and Director General of the World Health Organization, Dr. Tedros Ghebreyesus. Dr. Tedros, welcome to Rwanda. Yes. Before we So before we start, I would like to walk you through today's program. We'll first start by Minister Dr. Saban giving a presentation and overview about the Marburg virus outbreak. It will then be followed by Dr. Tedros giving his remarks, and then he will give us as well ample time to take some questions from the media. So thank you for joining, and Dr. Saban, the floor is yours.
Madam Chair, good morning, bonjour, Dr. Tedros, Director General of WHO, welcome to Rwanda once again. Ministers, Excellency Ambassadors, media, social organizations, colleagues, friends, everyone following us. So we're very happy to meet again. We've been having this weekly briefing since this virus was detected in Rwanda. And we're going also to be updating you again where we are, when we have some latest updates on some of the questions we've been asking ourselves, tracing back this virus, but also sequencing this virus, which is important for our response, but also important for the science and preparedness and response in general. So I'll be using a few slides so that we can have better visualization of some of this data before we get your questions, comments, and answers. So this is the simple way to put everything on one slide. This is the dashboard that we got from our command post. The teams have been working around bringing these statistics together, guiding everything we've been doing since day one. So as you've seen every evening, we're reporting new cases detected, recoveries, deaths, case fatality rate, and also how we track every contact. And you're very happy to say that in the last 5, probably 6 consecutive days until we confirm the test of today, with 0 new infections and 0 deaths consecutively. We wish this continues, but even if we had 1 case, for us is an opportunity to continue to trace every single contacted case before we put final end to this outbreak. So as you can see, we've done a lot of testing, more than 4,700. Using PCR is not an easy procedure, but we've always upgrading our capacity in every province. We have labs doing these tests. We've seen a trend of recoveries that was actually better than what was predicted, which is something also to highlight with the healthcare workers doing a great job to make sure every single life can be saved. I'll be showing some of the latest news about case management. So this slide has a lot of information. It's probably just to put everything together, but I'll be speaking about some of these highlights. But the most important information is 62 cases. We still have 3 patients that are not yet out of this treatment center. Hopefully some already having some good sign that we may get out of this treatment center soon, testing twice within 72 hours period. And unfortunately, we've lost 15 people, mostly healthcare workers, since the beginning of this outbreak. And we had also recoveries, 44 already back home. They are still being followed, but the good news is that they don't have the virus, and their general status is also improving. I mentioned the case fatality rate, 24%, which was really a result of a joint effort that all of you have contributed to. We've also seen that most of the patients we had were young, around the age of 30, 35, which is the workforce among these health workers. Maybe that was a factor that to think about in terms of case fatality and recovery rate, but also early detection and treatment. So in terms of gender, we've seen really no difference, depends on the service they're working in, but also we've seen that the early days were most complicated. That's where we recorded more death than the days we started to have now. You know, you detect, you treat, and you follow, including up to the ICU. We have also recoveries from intubation that we'll be talking about. So in terms of epidemiological observation, those who are in this field for some time, these are the best way to visualize the trend. The very first 2 weeks were a bit not different. That's the time we're still getting to the core of the virus. So many people that have been exposed or being tested. So there's no difference between week 1 and week 2 in terms of the infections. But we start to see a significant trend towards the week 3, where a 50% reduction was observed, which is the best indicator. You can see that an outbreak is dying when you start to see that 50% decline between week 1 and week 2. So we saw that at week 3, which brought a lot of hope that this is going to be contained quickly. And now this week, we're seeing even better results than 50%. We're observing 92% decrease in the infections comparing these 2 weeks, which is really a good trend that most of you have been observing online and our daily data published. But this is probably the best way to observe this trend and how we can get to an end very soon. So again, I mentioned before in the previous briefing that healthcare workers were the most hit. And the first on this left slide shows how healthcare workers were the most recorded infections. These are the cases by occupational profession. So the first one, you see the long green bar are healthcare providers, and the following box are actually students who are actually in the medical field. They are the hospital in those specific department, ICU. By the time this virus was being detected. So it explains the core of the virus and who was most affected. And their contacts are generally mostly the staff working in those hospitals, 2 hospitals. The case fatality rate, 24%, I mentioned about, and also the age distribution, which is also shown here, that majority were aged 30 to 39. So in terms of contact tracing, I see a number of epidemiologists in the room. This is probably one of the most interesting slides for you and for us as well. We can say that this outbreak was into one cluster. One cluster that had 3 major branches, the King Faisal, Sershika, and also the index case where our index case we'll be talking about, which also had family friends who were in the hospital by the time this virus was affecting the hospital. So this is what you've seen on our daily update, that there is a hospital cluster. This is how you can see that. The red dots are cases, and the blue are the contacts. We've been exhausting contacts and contact of contacts so that we don't miss any case. So this picture shows all those connections. And you can imagine how many contacts. Sometimes we're being receiving feedbacks from people saying, I'm listed as a contact, but I've never been in contact. But it's always better to know than to miss that. If you've been in this room, you may be considered as a contact, but that's how the number keeps growing. But it's also to show the level of exhaustion and search of cases that has been happening with most of your support. So there's a question that kept coming on where this infection came from and who is the index case or was the index case. So in the early days, the first 2 weeks, we had a case that we've been following from our initial testing, but I can say that after a deep search combining sequencing research, combining epidemiological search, combining diagnostic search, combining clinical information, and also One Health information, we came up to our index case, which is now known, and at least a very high probability and high precision that this is our index case, which is very closely linked to a zoonotic origin. So this is something we confirmed recently after all this testing combined, and that is going also to help how we adjust and increase our surveillance capabilities moving forward for this outbreak, but also for preventing potential future outbreaks. It's a very important information for us and for our partners who have been working and supporting to make these transmission chains and precision to a point where we can say we know the index case and is highly linked to zoonotic origin, which was also corroborating the sequencing results. This is our sequencing data that we've been working on in our lab with different partners that we thank. So the sequence for this virus in Rwanda is what you see. We call it October strain, which is very close to another strain genome that was reported in the region 2014, and also very close to a genome that was reported among in that zoonotic link that I talked about among bats in the region. So that information coming together, about 5 points of information connecting to what we see here as the sequence results actually put us in a situation to say this virus was from a zoonotic origin. It's very close to what we've seen in the region before, and that the virus didn't change that much in the last 10 years because the transformation, the change in the strains looks like very, very small, and that it didn't pass through different hosts to have had these mutations. So it's a very important information for those who are in this field. We talking about for colleagues who have worked on this sequencing, maybe for additional information. So we've had many questions about case management, how the clinical and doctors, nurses, alliance scientists, the IPC, and everyone came together to make sure we get the lowest case fatality rate in any Marburg outbreak before. Yet it came in a very difficult, unusual city, in the capital, in an ICU, in a hospital. And I would really want to pause here to thank all health workers, especially the teams that worked in treatment centers, to have managed to keep this case fatality rate at a very low level, 4%. And the answer to this is teamwork. And there are many efforts done on providing antivirals, use of different therapeutics. Some are in trials, some are already what we had to make sure the patients who were being followed, call them patient, but mostly they were health experts who are now being treated. They get the best outcome of this. So supportive treatment, even critical care, the ICU specialists who worked around this have done this possible. And we got great news Actually, yesterday I was Dr. Tedros visiting the treatment center, seeing that the 2 patients who have been on intubation for more than 10 days have been extubated. It's the best news you can expect in any treatments in any hospital when someone has been in intubation for a very long time, being extubated and doing well. It was a great celebration that these 2 people are going also to get out of this virus and go back to work. So this is something we want also to highlight, that even if you get this virus, you can get the best treatment and recover and even continue to contribute to the science, because understand this is the first time in the history that a patient intubated on Marburg yet extubated successfully. So, and probably the last slide is on the how Rwanda made sure we don't get virus out of our control. How do we make sure also we've been at our borders, we screen at the airports, at the entry points, at the borders, land borders, and water borders. So we continue to do this screening at the Kigali International Airports for these contacts, but also to make sure we don't miss any case. I want also to highlight that beside the list of contacts we had in our contact tracing teams, we've been following everyone with symptoms suggestive to Marburg virus to call us and tell us, and all we tested in the last 4 weeks, no one tested positive for Marburg, which is a great news that we don't have community transmission for Marburg. That's also a key indicator. And we are going to continue to do that because we are not yet at the end. That everyone with high fever, severe headache, muscle pain, with joint pain, fatigue, diarrhea, vomiting, calling 114, and we make sure we assess and evaluate and test, and that we don't miss any positive case, even if it's beyond our contacts. So with these past weeks, we've confirmed that all our positive cases came from our list of contacts. So that is up to now, and we are going to continue. It's not the end, but is a great step forward towards stopping this outbreak. So I'd like to also acknowledge other tools we've acquired, including vaccination, which came very quickly. It's rapid access and deployment of this vaccine that is one of the factors that we're seeing rapid containment of the virus. We've been vaccinating the care workers at the front line, the contacts of cases, and this also reassured those who are service, but those who have been in contact, that they're not going to get the virus. At least you have another level of protection. So we've reached more than 1,000 people receiving this vaccination. And we thank all our partners who have contributed to this effort. And they are here in the room, so we want also to appreciate his support. And when time comes, he may also make some comment on this. And so far, the uptake and the follow-up on any adverse events is going well, and we believe that is also a great contribution to what we can do when an outbreak happens, how quick we can deploy tools that are showing good success. So I thank you very much for your attention and look forward to your questions and comments. Bakoze.
Thank you so much, Mr. Dr. Saba. Now I'm going to invite Dr. Tedros to give a few remarks. Over to you.
Murakoze cyane. Amakuru. Murao. Owning my Kenya-Rwanda skills. Honorable Minister Sabin Sanazimana, members of the press, dear colleagues and friends. It's an honor to be back in Rwanda, and I thank the Minister for his hospitality and for his leadership in the response to the outbreak of Marburg virus disease. Last night, I also had the opportunity to meet with His Excellency President Kagame. And it's clear that he's closely engaged in the response to the outbreak. Leadership from the highest levels of government is essential in any outbreak response. And that's what we see here in Rwanda. And thank you, Mr. President, for your leadership. And thank you, Mr. Minister. We're pleased to see that there have been no new cases in the past 6 days. And we hope that remains the case. Yesterday, we visited the treatment center where there are still a few patients receiving treatment. Although most are now negative for Marburg and we expect them to be discharged shortly. We were impressed with the level of critical care for patients, which has not been used before in an outbreak of a viral hemorrhagic fever in our continent. 2 of the patients we met had experienced all of the symptoms of Marburg, including multiple organ failure, but they were put on life support. They were successfully intubated and extubated and are now recovering. We believe this is the first time patients with Marburg virus have been extubated in Africa. These patients would have died in previous outbreaks. This reflects the work Rwanda has done over many years to strengthen its health system, to develop capacities for critical care and life support that can be deployed both in regular hospital care and in emergencies. And I have heard this not only from local doctors, but also from foreign nationals who are serving in the treatment center and other facilities in Rwanda. They're very happy by what the standard of level is being in Rwanda. Although there are no approved vaccines or therapeutics for Marburg, we congratulate Rwanda for the speed with which it initiated trials of both vaccines and therapeutics. And we hope that these trials will help to generate the data to support approval of these products for future outbreaks. This also demonstrates the work Rwanda has done to strengthen its regulatory system, which has been working towards reaching WHO maturity level 3. And we hope the agency may reach the maturity level 3 before the end of this year. And I thank the many partners who have supported these trials, including the Sabin Vaccine Institute and the University of Oxford. And I'm glad that the CEO of the Sabin Institute, Amy Finnan, is able to join us today. Thank you, Madam. And as you know, we have 2 other candidate vaccines in the pipeline. I think 3 actually, from the Oxford University, from Public Health Vaccines, and IAVI. And I'm really glad that tropical diseases like Marburg virus, which is dangerous, is getting the attention, and we have vaccines in the pipeline. Yesterday, we also visited the National Command Center, and we were impressed with the way technology is being used to provide real-time information for action and enhance operational efficiency. As borrowing the words of President Kagame, I saw Smart Rwanda in action. And we also visited the BioNTech vaccine manufacturing facility. And I was here in Kigali for the groundbreaking ceremony 2 years ago. So I was very pleased to see the significant progress in construction. One of the key lessons of the COVID-19 pandemic was the need to expand local production of vaccines to avoid inequitable access to vaccines that we saw. And we're pleased to see the way Rwanda and BioNTech are investing in local production. And you know how Africa was treated when the vaccines arrived. The vaccine inequity and vaccine nationalism. And we hope this strategic investment will address the equity problems we faced in COVID-19. So, as I said, we're very pleased that there have been no new cases and deaths in the past 6 days. And I can see that the outbreak is being managed under strong leadership. But we're dealing with one of the world's most dangerous viruses, and continued vigilance is essential. Enhanced surveillance, contact tracing, and infection prevention and control measures must continue at scale until the outbreak is declared over. WHO will continue to support the government in the response. Together with our partners, we have provided technical experts, personal protective equipment, test kits, and other supplies. And I thank especially the United States, the European Union, and the United Kingdom for the funding they have provided to WHO and other partners. And I salute the dedicated health workers who have put themselves in harm's way to save their colleagues, and who have continued to work despite the risks. And I honor the memory of those we have lost. I would also like to reiterate that based on a risk assessment, WHO advises against restrictions on travel or trade because they are unnecessary and can harm Rwanda's economy. Except harm, it doesn't bring anything. I mean, the travel trade restrictions. I cannot really emphasize enough, especially this point. Of course, most countries have respected that advice, but some have imposed travel restrictions. And we ask those countries to reverse those restrictions. Honorable Minister, thank you once again for your leadership. And I assure you of WHO's complete commitment to supporting you in any way we can. Murakoze Jane. Thank you so much. And moderator, back to you.
Thank you, Thank you, Dr. Tedros. I think I got a bit choked up by the good remarks. It's just like the reinforcement of support, so thank you very much for the remark. I would like to take an opportunity now to give the floor to the room and take a few questions from the journalists. So before we'll start with the first round, I would like to ask for a few housekeeping rules. Let's keep the question brief, so everyone has time at least to be able to address the questions. Thank you. Already so many hands. We'll start with RBA.
Thank you. I'm Adam Squeezy. I work for RBA. And my question goes to Dr. Tedros. Those are two questions. You reiterated even in your remarks this, but we want to hear you from your own opinion. How would you assess Rwanda's response to managing this Marburg outbreak? And the second question, Doctor, we saw you visited the BioNTech plant, which is even to start producing vaccines by next year. But then, how do you think this will take for Africa to produce life-saving vaccines for Africans here on this African continent? Thank you.
Dr. Tedros, you can answer the first round.
So the first question, if clarify a bit. Are you saying how do you think Rwanda is managing the outbreak? Is that what you said? Okay. I think I have said already in my speech, I actually focused on that. The key ingredient in any outbreak response is leadership, ownership by the leadership. And that's what I said I have seen. And I met His Excellency the President yesterday, and the knowledge he has about what's happening and the measures they're taking is heartwarming. He's on top of it, and I was so glad, because in emergencies like this, in outbreaks like this, the role of the top leadership is very important. But not only that, the way they moved fast as soon as the first case was reported was really fast. For instance, therapeutics started within days actually. Imagine the logistics of having the therapeutics and start using it. And vaccines, I think within a week, and all the approvals and so on expedited. That's leadership again, so the response was fast. And then if you see the number of cases declining significantly, as what Mr. said, over 90%, I think. And 0 cases, 0 new cases, and 0 new deaths since Monday. And we can see now a significant decline. And then the surveillance, we have been to the command center, I think is really strong. And I can mention other factors as well. And it's not just from my observation, but I have spoken to both nationals and also foreign nationals who are already working directly involved in the response, and they're very happy by the strong response of the government. So that's very important. So it's well managed, to be honest, and that's why the risk is also low, and that's why I say the travel restrictions, WHO's advises against it, and there should not be travel restrictions. And especially when you have a government, a country that's taking responsibility, it's good to encourage rather than try to take those measures that doesn't help. So that's what I would like to say. On vaccine, the BioNTech, as I said, 2 years ago I was here, and the speed of the construction is really good, and I hope they will move into production as soon as possible. Of course, the date is not yet fixed as next year. Still, I hope they will start production based on the schedule they have. But this was based on Africa's experience, especially during COVID, that Rwanda is really pushing. And one thing that I was happy to observe, and which I was briefed by the experts there, was this manufacturing plant is not going to do the, what do you call it, the fill and finish only. As you know, in many plants in our continent, they just do fill and finish. That's basically for the packaging, and then they claim that they are producing. Meaning the contribution to the value chain is very small if you're only doing fill and finish. Then what does it mean in terms of creating jobs, and then even in terms of making the plant competitive if you don't cover the big bulk of the value chain? It's nothing. But something special about this manufacturing plant is it really accommodates most of the value chain, including the fill and finish, and which can make it more competitive. And that's very important, starting from the first process, end to end. So that's very, very important. And I hope it will be more competitive. Not only vaccine production, it will also create jobs. It will contribute to the economy. By the way, we should not see it as part of just producing vaccines only. And it also brings opportunities, economic opportunities, creates jobs and improves the economy. So we should see that. And the commitment from the government to produce vaccines, from my exchanges, including with the President and the Minister, is exactly that. It's as part of the economic development. It's not just producing vaccines for the case of producing vaccines, or just only to address the equity issue. It's more than that. And I'm glad it's, that's the basic principle. And I hope this will contribute to vaccine equity in the future. But we have other initiatives as well. As you know, the mRNA transfer hub we established in Cape Town, South Africa. And 15 countries are involved. This is on top of that, by the way, Rwanda is doing this. And the 15 countries are from Africa, from Asia, from Latin America, and even from Europe, benefiting from the mRNA transfer hub. So I think when we build local capacity in those countries, I think we can address the equity problem that we have faced during the COVID-19 pandemic. And from our side, we will support Rwanda and support also other countries who are working on this. But as I said earlier, those countries already investing are seeing it as economic development, not just as vaccine production only or as equity issue, as part of their economic growth and as part of their national development, and that's what has to be. So thank you for these two very important questions.
Thank you, Dr. Tedros. We'll take a second question. We'll take it from Bloomberg.
Hello, my name is Indira. I work with Bloomberg. I have a couple of questions. First to the Minister of Health. I just want you to map for me, one, the vaccine trial and also other treatments. Who are you focusing on and what kind of data are you getting out of these treatments and vaccine trials that you're doing? And also you mentioned that the number of cases have been sharply dropping. My question would be, are you confident enough to say that the cases have peaked, and so far what have you learned? And to Dr. Tedros, in the last 5 years we've seen a lot of outbreaks globally, some like COVID, others at a smaller scale, but global health emergencies. What is your take on insurance, particularly for countries like Rwanda? It depends on lines, and in the last couple of months we've seen some jitters in the market about coming here because of the health directives. Thank you very much.
We'll start with Minister Dr. Salah.
Good. Thank you very much for the question, coming from Bloomberg. The vaccines and therapeutics we've been using were mostly to try to save the lives of these people who were infected by the most deadly virus that we know. And for the vaccines, it's also important to cut the chain of transmission. So the close contacts of those who are acquired the virus receive the vaccine so that they don't develop the virus disease, but also we don't get new chains of transmission. Third is also to protect the healthcare workers. As you've seen, they got this virus while treating patients. So you want to be in a situation where healthcare workers are protected as much as you can. We have infection prevention control measures, but getting this vaccine is probably the best way to get them protected and feel comfortable at their work. So these are the main groups we've been targeting. First, to treat with these therapeutics, but also to protect and to cut the new chains of transmission for the virus. So these have been our main targets, and even as we continue to use these tools, we'll be seeing the risks and who is at most risks, because we don't intend to vaccinate everyone or to give post-exposure treatment for everyone. antivirals to everyone. It's really targeted therapies based on risks assessed and how we can stop this transmission quickly. So on the whether we are confident that this we're getting to zero, this is our wish, and our teams are working really hard to make sure we don't miss any risk or any case or any contact, because that's where you expect to have the next case. That's on the side of transmission. But also on the side of treatment, we don't want to lose any other life. That's why I was emphasizing on the fact that the two patients who were very sick, but we experienced all the symptoms of Marburg virus that we described before, were able to get extubated. That's really a celebration for us, because we cut transmission, but also we save the lives of these people. We're talking about doctors, we're talking about the most experienced people who will take care of us when we get sick. So protecting them is even protecting ourselves, all of us. It's very important. So when are we going to get to the final end of this outbreak, this virus? It's an important question. So we're all watching, but what we get as a trend, as a result, depends on our investment, the efforts we put in. So we continue to do searching of cases, continue to follow the contacts, continue to apply these tools. We're doing door-to-door, for example, across the country. Every single household is checked with community health workers to make sure. Even if we miss one case, we'll detect it from household level, or from facility level, or from anyone else who may say, oh, I have something, please check if you didn't miss this thing. So we have to wait a few more days per the guidelines. Actually, WHO guidelines suggest that once you get zero, countdown starts until you get to 42 days, and then it's completely out of it. So now it's 6 days down the road. Still checking, and continue to put our alert at the highest level. Thank you.
I'll now pass the floor to Dr. Tedros.
Yeah, thank you. You know, the increasing frequency of outbreaks, true, and that shows our vulnerability, by the way. And we still are not prepared. But now I think maybe we're changing the tide because of the COVID lessons, that we are doing more, starting from, for instance, the pandemic agreement. The pandemic agreement is developed based on lessons learned from COVID. And if that's agreed, will be very important to prepare the world to prevent the next pandemic, to early detect and or to early detect and respond rapidly. But while, of course, the negotiation is progressing on the pandemic agreement, there are many things that are being done based on the lessons learned. For instance, the pandemic intelligence hub, which is based on the lessons learned from the challenges we see in surveillance. And then the bio hub, which is based on the lessons learned because of problems related to sharing pathogens. And then the peer review mechanism is a UHPR. And I can go on and on, including the pandemic fund, which is established now, and supporting countries to build their capacity, because national capacity is the most important. So if you ask me in terms of insurance, that's the best insurance, to prepare. To prepare, and especially for a strong capacity at national level. And with the basic principle that we are as strong as the weakest link, and to really invest, especially in countries with weak capacity. Because no one can be safe if all of us are not safe. That's the best insurance. Of course, on top of that, then there are some discussions on, okay, when major pandemic hits or epidemic hits or outbreaks, what kind of insurance can be designed and so on. There are some discussions, some models being discussed. I think still it can be, that discussion can go on and the models can be tested and so on. I think not only on pandemics, there was a model also that was tested on drought, for instance, on famine, with the same experience. So that could be done, and I hope the discussions will progress. But the most important insurance is strong pandemic preparedness and response, and do it as with sense of urgency. As you know, we see this cycle of panic and neglect. The whole world panicked when COVID hit, and there was a lot of investment at the height of the pandemic. But now, the attention and investment is shifting from one to other priorities. Of course, when there are competing priorities, that happens. It's not a surprise. But there is nothing more important than health for any country. So health should get its right attention, and investment, especially in health systems, strengthening and in pandemic preparedness and response, should continue. And that's the best insurance. Thank you.
Thank you, Dr. Tedros. Many questions. I think I'm also going to take a few questions from online because we do have some people that are following. We have a question from Science Magazine, Kai Kumferschmidt. It's addressed to Dr. Saba. Could you give more detail, please, on the likely index case and what is known about any potential zoonotic exposure, where and when?
Thank you, Kai, for Science Magazine. I think this is a very scientific question that try to answer now, but also be answering in details once we publish most of this data for global scientific community. So we, as I said before, combined several efforts, including review of patient files at one of these hospitals, actually both hospitals. We combined sequencing efforts that we presented for the first time, the sequence we did here in Rwanda. We also conducted serology testing for people who may have been exposed to try to find where, who met, when, and how. We also conducted epidemiological investigations on contacts, starting from where we confirmed the first case. Additionally, we did also environmental and animal search and testing. So the index case we presented here today is a 27-year-old male we traced back in our contact tracing, starting from the hospital, from all the 5 elements we put together. And that led us to, with actually high precision, that this is from a zoonotic origin, that this man has been exposed in a particular area in a cave with specific species of bat that has been sequenced before in the region. And that is how we get to confirm that this is linked to outbreak we are dealing with. So in terms of when, it's actually very recent. It connects exactly to the chain of transmission seen in the hospital, where this particular individual person happened to be treated at an ICU in King Faisal Hospital. So that is where we started to see the healthcare workers who attended on the contact index case. And we got to know what we all know about the next phase of outbreak. So getting to that index case has been a result of several efforts, several diagnostics, lab science, AP data, and you're very happy to know that because in most of outbreaks it's very, very difficult to even get to that point. So we continue to expand and even understand these dynamics from a One Health context. And that's why we will be providing more details about this index case and potentially how we get ready for preventing future outbreaks. Thank you.
Thank you. I'll take 2 more questions. Let's go with Katie Press.
Thanks very much indeed, Honourable Minister, Director General, Minister Katie Press. You talked about the treatment, the success of the treatment. Clearly something new here. Could you tell us a little bit more on the experimentation, what you've done that is making such a huge difference? And also, once people have recovered, you clearly keep following them up for a few days, but then what happens next? And you talked about the index case. Is there something that can be done or can be suggested to prevent this zoonotic connection? Or is it something that simply can be looked at? And from a healthcare point of view, is there something you've learned that when or if, we keep hearing that it's really a question of when, never if. When this happens again, something can be done even quicker than you've done so. And if I may, very, very quickly, what does the end of Marburg look like? What would you say? At what stage would you say we're now free? And if I may, very quickly, Director General, clearly something new has happened in Rwanda in the treatment of Marburg. Is there a case for saying to them, you now have to put everything together that you've learned so that that can be part of the standard treatment elsewhere if this virus arises again? Thank you very much indeed.
Yes.
Thank you, friend from Katie Press. I think these are key questions. The first one has been probably asked before in a different way, but it's an important question, can't exhaust that. What are we learning from this? How the treatment outcome came together with a very good picture, 24% case fatality rate. I would say that it was a combination of efforts, both from our local medical and health teams in general, but also from global support from scientific community, or the tools that we had in hand and how they came together very quickly. So it's that, I would say, teamwork or efforts combined, but also the guiding principles, what can we do to make sure we save these lives? And these are things we're still learning. Of course, this virus is very well known that the earlier you start supporting treatment, the better the outcome will look like. And we knew that also it's very aggressive and that you need to be very close to the patients. Some were quickly going into complications, multiple organ being affected. Others were taking some time. So our medical teams and health teams were also learning through the process. The early days were very difficult. That's actually we recorded the highest mortality rate. But after some days, they adapted quickly. The infrastructure they're working in was also conducive, at least to what we've seen. Having an ICU within the treatment center is something that has not happened in the previous outbreaks on the continent. And we've been addressing every single need in the fastest way we could. And we've been calling to different partners for anyone who has any tool to come in quickly. And we've seen this global partnership and support really coming very, very quickly. The sense of urgency was everywhere felt. So I would say this is how you can try to explain what we're getting as an outcome in terms of saving these people's lives. Knowing an index case can never be 100% sure, but at least you can get close. That's why we're saying there's a high probability, the high precision, that this is the one, the index case. initially. We had another index case that we traced back and found more information actually linked to that case we talked about first week. That is how the science evolved, how the search of data and information. So that's why we are not going to stop, we continue. And it means a lot in the One Health context. And for those who are not familiar with these terminologies, One Health is all about how humans, animals, and environment come together to live in a balanced way. And whenever there is imbalance or a change in this harmony, you get complications. You have diseases coming from humans to animals, environment, or the other way around. And the big lesson we're learning from this outbreak, based on India's case, is how do we make sure these principles of One Health are addressed, and that how do we build strong surveillance mechanisms that what is happening in the animals is known, and in humans, environment, from research surveillance perspective, how do we get to this genomic surveillance, coming in together the lab, the epidemiology, and the clinical surveillance on a regular basis. So we know early and we respond quickly and we adapt in real time. So I believe after this, there's a lot of experience, there's a lot of guidelines, and change is going to happen. That is for us another task to do, adjust what we've been doing. To give you an example, all past Marburg outbreaks on the continent happened somewhere in the village, far from main cities. And the containment measures have been actually locking that particular area and trying to treat people within mobile tools, or creating hospitals, the health centers there, with probably not the same level of standards and capacities. So today we are talking about an outbreak coming from capital city, in the top hospital and the most affecting most experienced healthcare workers in intensive care unit. This is new, and we're learning from it, and we'll be adapting accordingly, I'm sure, from a global context perspective, from preparedness that Dr. Tedros was talking about. We're going to adjust a lot of things, particularly on hospital-based surveillance systems, and how we bring public health within clinical care management together on a regular basis. So, I mean, lessons are a lot, but let's, for today, pick what we can get and continue to have conversation, because the outbreak is not yet over.
Thank you, Dr. Saba. I would like to take one last questions from our being
Okay.
Rwanda.
There was one
My
question I
apologies.
think he asked me. So I will be very brief, so you can give a chance to the one you already identified. I don't want to so it's clearly good practices, I think, from this response. And I think we have to document those, as you have already said, for future responses. Not only WHO, but other partners as well, especially for the continent. We have Africa CDC, and by the way, we're working very, very closely, WHO and Africa CDC, and we will together and other partners document the best practices and then use it for future responses. Thank you.
Thank you very much. All right, with the last one, we'll do it in our native language for RBA Rwanda. Thank you.
Thank you so much. My name is Fisto Felix Antoneza from RBA. Here's my question to the Minister. I want to ask it in Kinyarwanda. Tumaze iminsi nk'uko mumaze kubivuga tutabona abahitanwa n'iki cyorezo n'ibipimo no mu bipimo bifatwa tubone abanduye bashya. Umuntu yavuga ko twageze ku ntsinzi, ariko kandi ko bikiryamisha n'uburyo abakize bakurikiranwa gukomeza imirimo n'ibindi. And I would request you to ask in Kinyarwanda as well. Thank you.
Dr. Saba.
Bakoze. I thought Dr. Tedros will answer his Kinyarwanda. It's actually good. So byiza by'aho icyorezo cyerekeza. Tumaze hafi iminsi 6 ntawanduye iyi virusi ugaragaye gushya, ndetse n'abitaba Imana ntawe twabonye muri iyi minsi 6 ishize, bigatanga icyizere n'ubwo icyorezo kitararangira, ariko bikanatuma dukomeza imbaraga zose kugira ngo haba hakiri icyuho, haba hari umuntu umwe cyangwa wahuyemo n'uburwayi tutaramenya, tube twabasha kumugeraho, bityo tugere ku ntsinzi baruvuze mu buryo budatinze. Ku bakize nibyo turagomba kubakurikirana. Gukira kuvuga ngo wapima inshuro 2 ugashiramo amasaha 72 bigaragaza ko nta virusi iri mu mubiri wawe, ariko mu bigaragara ni virusi ikiri kwigwaho cyane, kureba ngo wese nyuma y'igihe runaka ni gute tuzakomeza kubakurikirana. Kuba twamuhaye yatashye yakize uko tuba twizeye ko iyo virusi mu by'ukuri dushingiye ku bipimo bihari umuntu yakize, gusa bazakomeza hari uburyo tuzabashyira mu itsinda rikurikirana yuko nta kindi kibazo cyaba kuri bo ndetse nabo babana, ariko turashaka gushimangira ko batagomba guhabwa akato ako ariko kose, kuko gukira indwara nyine buri wese ashobora kurwara indwara ye yose, ariko gusubira mu rugo abantu bagatangira kuvuga bati uyu nguyu yarwaye iki n'iki, ibyo turabirwanya cyane. Ahubwo tubafashe, tunabegere mu kazi, ahandi no mu ngo, aho tubana nabo mu muryango, aho tuzi, kugira ngo bumve yuko igihugu twese n'umuryango nyarwanda ndetse n'ababa mu Rwanda twese tubashyigikiye, kuko baciye mu bihe bitoroshye, ariko tuzakomeza kureba ubuzima bwabo. Niba hari n'abatarakira ibisigisigi cyangwa uburyo icyorezo cya virusi yabashegeshe, ariko hari n'abatarigeze bagira ibimenyetso bikomeye, bahise umubiri wirwanaho, bafashwa kuba bayitsinda mu mubiri wabo. Rero twese tubabe hafi, tubashyigikire, ndetse n'imiryango yabuze ababo kubera iki cyorezo cyabahitanye, benshi n'abaganga batuvuraga nabo dukomeza kubihanganisha cyane, tukaba hafi. Numva ari byo nasobanura. Abanyarwanda dukomeze dushyire hamwe n'ababa mu Rwanda bose, abafatanyabikorwa, kugira ngo tugere ku ntsinzi burundu. Biri hafi, ariko n'icyazamuka cyose kidutunguye turiteguye kandi dushyize hamwe. Bakoze.
Thank you. Maybe let's
Can I answer in Kinyarwanda?
that would be lovely. I think your Kinyarwanda is good enough.
Nishimiye kuba mu Rwanda. Dabara mukuji kandi nubaha abaturage ba Rwanda. Does it make sense?
Yes.
Yeah? Murakoze cyane. Ndagukunda Rwanda.